So what I'm going to discuss going to be from the neurologist's perspective. So I'll just give you some idea of particular sequences we as neurologists look for, and then what are the limitations I came across after I came back to Pakistan. So let's start with today's presentation, and thank you very much everyone for your presence today. I will appreciate if there are any questions, please raise your hands and I'm happy to answer those questions. So neurology has a huge scope in the field of medicine. As a matter of fact, it has, other than radiology, I think no other specialty can beat neurology in terms of the extent of care. So when it comes to neurological disorders, in my institution in the US, it was one of the most consulted service in that institution. And you can see in your daily practice as well, how many patients come for imaging for neurological disorders. So almost any systemic disorder do have neurological manifestation. And the burden of the disease is progressively increasing. And the main reason for that, despite the fact that care is improving, but what's happening is that our aging population is increasing, which is Alzheimer's dementia, any kind of a dementia goes higher as patients grow more old. And with the quality of care improving, naturally there are more and more patients. And also if you look at the burden of the stroke, it's again huge compared to any other disease. So it's actually number 2. If you consider trauma, then it's number 3 in terms of the burden of the disease. So the first pie chart is for the disability adjusted life years, and this is for the deaths. So you can see how many number of patients they actually die because of stroke, because of dementias, because of Parkinson's disease, because of trauma. But in the disability chart, another big chunk is headaches, including migraines. So this is another chart showing you the age-wise distribution of what we see from the neurology disease perspective. And if you look at again the same color, so the stroke kind of picks up right from childhood, even in the neonatal area, in the neonatal age group, kind of become a bigger chunk later on after 50s, and it kind of goes down, but naturally the aging population come down as well. And the dementia increases in that age group. And in those patients, aspiration pneumonia or other complications kind of increases over time. And this is for the headaches and migraines. So as I said, I'm not trying to teach you guys. You guys know way more radiology than me. So I'm not trying to teach you guys, but we're going to discuss is some basic sequences, and naturally those basic sequences we all know. Diffusion weighted images, and I would like some interaction by the junior residents. How many of you have seen diffusion weighted images and you know how to interpret those images? So if you can raise hands, it's a very, very basic image, but I want to know where you guys are, because I know in Multan there is 1.5 Tesla imaging, there is 0.5 Tesla imaging as well. So any of you, or how many of you have seen diffusion weighted images, and how does it look like? So just 1 per 2, okay. So 3. So 3 people have seen what a diffusion weighted image looks like. So whenever we do diffusion weighted image, we have to do ADC, which is apparent diffusion coefficient. So doing one diffusion weighted image will not add anything. We need to do an ADC map to say, is it a correlated image or not? So just for the understanding of the junior doctors. The very basic image everybody knows about is the T2 weighted image. Okay. Then comes the flare. I believe you guys must know the difference based on if it's not labeled, how you would know. There are many ways. I know 3 ways to differentiate if it's not written. So T2 star or GRE or gradient echo imaging, T1 weighted images. Naturally, there are other special sequences, but what I would like to emphasize on is the susceptibility weighted images and the perfusion weighted images, because I believe the special software is required when we do these particular type of imaging sequences, and they have their own importance, especially when we are looking for patients who are not typical straightforward patients. Okay, then comes the sections. So we all know axial sections, sagittal, coronal, there may be more, as a matter of fact. I don't know many, okay? But the other thing I would like to stress upon is when I'm looking for some particular pathology, I would love to see thin sections. And I'll give you some examples. That's why I would like this presentation to be somewhat more interactive. Okay, now recognize the sequence. I already know the three who raised hands. So which sequence is this? Diffusion weighted. Like I hear more voices than hands. Okay, so this is diffusion weighted image. And what's this? This is ADC. Okay, great. So you need to pick it just by the image. That's why I didn't label it. Okay, which one is this? GRE. Great. So you guys know all the basic sequences. Okay. Now coming to the screening imaging protocols. So as we just discussed about the diffusion weighted images, we can do in any section we want to, but what we basically look for is the axial section. Apparent diffusion coefficient, because this is a particular sequence for stroke patients or vasculitis patients, so or any vasculopathy patients. So in those cases, we need a diffusion weighted image, but it should be part of any basic brain scan. So any patient who is coming in for any MRI, this particular sequences should be there. We can do on top of this. Again, this is what I have seen internationally, and this is what we tried to do in Mukhtar Sheikh Hospital as well when I was working over there. Okay, so any patient coming in for any screening MRI should have basic sequences. Then the T1 weighted images, which is most of the time it's there. T2 weighted images, again, this should be done in more sections. And I'll give you the idea why we need to do that in more sections. FLAIR, again, it can be done in axial, and in particular scenarios, it should be done in other sequences and other sections as well. And GRE, again, in axial. Well, I'm going to have some questions. So coming to the stroke part, as we discussed, the diffusion weighted image, apparent diffusion or ADC map images, we need to correlate both, as we have seen in our first image. T1 weighted images again gives you the idea if there is a hemorrhage or not, or if there is a calcification and you're confused what is that. So that will give you some idea. Next, there is a whole differential diagnosis when you see some abnormality on T1 weighted image. Again, I'm not going into the differential of those. So FLAIR axial is very important in the stroke patients when we are timing the stroke. So first image will give us the idea if it's an acute stroke or subacute stroke. But if it is chronic, FLAIR image will give us the idea. And I do have some examples. Again, T2 star to make sure if there is a hemorrhagic component in the stroke or there was an old hemorrhage. I know as the TPA or the medicine for the acute stroke patients is approved, I really hope in next 3 to 5 years time you're going to see way more stroke patients in the acute phase than right now. So we need T2 star images in those cases, because if there's a hemorrhage already, these patients are not candidate for TPA. And this should be done, there's a window, so we need to do it as soon as possible. Perfusion images are done as part of the protocol. It's not routinely done even in the stroke patients depending on the center. So what we were doing in the US was the CT perfusion images. But there is MR perfusion images you can do. You need the software, you need the people who can interpret it. Again, this is very helpful to time stroke and to give treatment, acute treatment for stroke. I hope many of you know that the treatment for stroke involves giving TPA in first 4.5 hours, just like cardiology patients, and it really saves them. Okay. Now, coming to my point of why we need to do the T2 weighted images in all the three sections. My consultant, one of my senior colleague, very well published, he used to say this is the angiogram of a poor man. That will give you the idea of the vasculature. Even if you're not able to get the CTA, because the CTA involves many more things. Infusion pump, correct timing, good ejection fraction, all those factors are there. So this is one thing which will give you some idea. So the T2 weighted images should be done in all three sections. Okay? And we discussed about the perfusion scan. So it has happened with me many a times that I see a report and the radiologist says there is a stroke. Okay? And personally, I don't see ADC and diffusion weighted images. Okay? You cannot say it's a stroke. It's just a hypo-intensity. It could be stroke based on the history. but it doesn't clarify the question. And how old was the stroke? So this is a common mistake I have seen in everyday practice, because most of the private MRI in Multan, they are 0.5, 0.7 Tesla. They don't do DWI images. And the technicians, they even don't know how to do it. And even if they do it, they don't do ADC map. So how are you going to say it's acute stroke? It's not something else. Okay. The other common mistake I came across is patient is reported to have a large vessel stroke, which is actually a big thing. If somebody write down large vessel stroke, it's very obvious right there. But you have to say why patient has both MCA and PCA involvement at the same time. Is it a fetal PCA? So what I usually tell my medical officers, even my residents in neurology, there is no limit to perfection. You can always improve yourself. Okay? More and more you will pay attention, more and more you're going to learn. So every patient gives you something to learn. Even today I saw a patient, I don't see patient on Saturdays, and I learned from that patient as well. And actually some of the images I have to include in this today's presentation. Okay? So in reporting, please, whenever you report, make it in such a way that whoever is reading it will be able to say, oh, it's a great radiologist, a good radiologist. He reported the type of stroke, the location of stroke, what could be behind that. It is embolic, it is a lacunar. How many of you know what a lacunar stroke is? What's the size of lacunar stroke? Yes, please.
The lacunar stroke are caused by obstruction.
No, the size of lacunar stroke.
They are very small.
How small? Any more guesses? Less than 15. Okay. So there is something called lacune, then there is something called megalacune. Okay. So usually up to 5 millimeter. Okay. But 15 millimeter and below. If it is 15 millimeter and above, and what's the difference? Why it creates a difference? Because if the DWI is not done, everything is messed up. Okay. So, but when you have this information, it really helps you decide the medicine of the patient. It helps you decide the next investigation of the patient. Do you really need a CTA? Do you need an echocardiogram or not? Okay. So that's why these are very key points for any patient. So what do you think about this patient? What particular sequence is this? Any guesses? DWI, yes. What you're afraid of? Just you already guys, you told me before. So what do you see? One here, one here, one here. What's going on? What kind of stroke is that? Any idea? If you're going to report it, what kind of stroke is this? I told you the stroke is the biggest burden of neurology. You guys may be seeing stroke almost every day, many patients. Okay. So what particular type of stroke is this? Okay, any more? So there are like 3 or 4 lacunar strokes at the same time? Any more guesses? It's the same patient over here. What happened over here then? If that was a lacunar stroke, what happened over here? Have you guys ever heard of watershed stroke? This is a watershed stroke. How do I know that? The appearance of it, you see there are multiple small changes or hyperintensities, and then what we call the string of beads, that's the appearance of it. So as soon as, okay, the first part is a watershed stroke. Okay, what should be done next? That's a question from a clinician, from a neurologist. Okay, but the radiologist should know that. So the best part, what I like working in US, we as neurologists, we never spared our radiologists. And our radiologists, they never spared us. We keep coming to each other. What do you think is going on? What do you think is going on? Because it's a mutual learning. Okay? So, this is a watershed stroke. Then, if it is a watershed stroke, what happened over here then? What particular sequence is this? Sorry? It's a flare image. Great. So, it's a flare image. So what's going on over here then? What do you think about these two? These were not there before. So these are old strokes. Does this stroke and this stroke matches? No. For sake of time, I know it's taking long. So these two strokes doesn't, because these two are embolic. And this is watershed. And the etiology for watershed is critical stenosis. And that critical stenosis is somewhere in the neck vessel, in the intracranial vessel. Okay, so we need to know that. So the next imaging for this patient is going to be CT angiogram. And in this particular, that's what I was teaching my radiologists when I was working in Mukhtar Sheikh. I mean, you guys know a lot of stuff from the radiology perspective, but when they ask me why we need a CTA, guys, if we're going to reduce the blood pressure of this patient, he's going to stroke more. It's such a critical piece of information. It's a very critical piece of information. Okay, coming to the vascular imaging. Okay, so in these patients, we need MRA. If you suspect it's a venous stroke, then you need an MR venogram. Okay, and it does happen that you may not get the information you are looking for. So the clinicians, physicians go by theory, by hypothesis. I'm thinking this is what it is. Okay, and it's not proven. Either I'm wrong or I need to look more. So you have to be how suspicious you are. How strong is your suspicion? Okay, and then you can do CTA, CT venogram, which gives you somewhat better imaging of the vessel wall compared to MRA. Okay, naturally there are other modalities, other magnets, whatever you can play around. Someone may be more comfortable with one type of imaging as well. There is always a possibility. Okay. Then you can do high resolution thin section enhanced T1 with fast PEST, looking for what kind of plaque it is in the neck. Is there a hemorrhage in it? Is it a fibrofatty plaque? What kind of plaque is it? That will help you decide your lipid lowering medication. When I started writing down according to the standard protocol, atorvastatin 80 milligrams, even the pharmacist called me. Dr. Saab, this is not the dose we prescribe. I said, this is the standard dose because nobody writes it. Okay? That's the problem. We don't do evidence-based practice. We say evidence, but we don't follow evidence because we don't read evidence. That's the problem. Okay? And what saves my life is the digital subtraction imaging, okay, angiogram. And that is where the technicians come in. Because if they do a great job, it saves the time of the clinician. Okay, but sometimes you still need to look at the raw imaging. But if it's a case of RCVS, reversible cerebral vasoconstriction syndrome, you need to do interval DSA. So after medication, those vessels open up or not? What's the age of the patient? So what I will recommend today's presentation, that you guys, if you want to learn, please get back to your clinician. And if the clinician want to learn, they should get back to you. Okay. So you need to do digital subtraction imaging in that case, okay, to see the change. Then if it's a subacute stroke, by the time of it, it may mimic like tumor many times. I was many times deceived by that. So you need to do contrastive study. You need to know the time. Still, rarely you get deceived as well. Is it some kind of a mass or is it a subacute stroke? Okay. Then you can do conventional angiography, okay, for cerebral venous sinus thrombosis. You can do CT angiogram as well, depending on what's available, because the conventional angiography is not available very frequently. Okay. So as we just discussed in the reporting, if it's a watershed infarct, be sure about that. Write it down in your report. Okay. You may be wrong. Put a question mark there. Okay. But report it. If you will never report it, you will never learn it. Okay. So you start reporting things because it will become easier for someone who's not a neurologist, who doesn't know what's going on. Okay. And then you have to look for the location of the stenosis. You can look at that in the T2 weighted images if other images is not done, if you're interested. Okay. Otherwise, you can say some kind of vascular imaging is suggested to look for the critical stenosis. It may clarify because there are close to 250 to 300 neurologists in the country. Okay. We have such a huge population. There is one neurologist for 1 million patients. I, in a whole lifetime, cannot see 1 million patients. I can't even see 100,000 patients. Okay. So we need to work together because any of us can be a patient. So this is what I was talking about. What do you see here? CT angiogram, nice. And what particular section it is? Coronal. And what's this? It's a critical stenosis. Okay. I had a patient, young girl, who has been to Multan, to Karachi, and Karachi to Lahore, and then back to Multan, and she was just 14 years old. Fibromuscular dysplasia and recurrent strokes. She even developed dissection of the blood carotid vessel. Okay. So I personally never diagnosed a patient with fibromuscular dysplasia. I saw some patients before, but I never diagnosed myself. That was my first patient. And I was like, oh gosh, what's going on with this patient? I immediately contacted my colleague in the US. So always have a colleagueship. If you're not understanding anything from the neurology perspective, check with your neurology colleague. Okay? Be friend with someone. Okay? Or some other specialty colleague. I was like, what do you think is going on with this patient? Okay? That will help you. Okay? And nobody actually minds it. Unless you send a lot of images, nobody actually minds it. Okay? Now coming to the next. I know it's going to be somewhat pathology based. So for epilepsy, except for the general protocol, what we discussed, and I'm happy to send these slides so you guys can have it, technicians can have it. Okay. So beside the general protocol, we have to do FLAIR coronal sequences. We did the axials before, but now coronal, we need it. Okay. And T2 weighted images, again coronal. We did before, yes, but I'm stressing upon it. And thin cuts through the anterior temporal pole and hippocampus. And somebody can tell me why. Mesial temporal sclerosis. Okay. Because as a radiologist, you don't get the whole detail. Okay. You don't get the history maybe most of the time. Okay. But you have the right to ask the clinician why they're doing scan. At least write down one line. Or I write down dementia. Why I'm doing this scan. At least one word you can write. You can ask, like, as a departmental policy, next time if this is not written, why this patient is having an abdominal scan, we cannot scan the whole tummy. Saves time. You want to look at the liver? We will look at the liver. We will reduce the cost for the patient and time for you guys and increase the productivity. Okay. Same goes for the brain. If you want the pituitary sequences, you get the pituitary sequence. We won't do everything. Okay. So that's where I'm interested. And if it's already in the system, the scan will just run it. You don't need to put the sequences later on. That, oh, we need to do, this is epilepsy patient, we need to put these sequences in the mix as well. If it's already set, as a matter of fact, in my institution in the US, they labeled it by the name of the epileptologist who actually gave the sequences. So they just, Abu Khalil's protocol. They don't mind it. Okay. And then the very important key, I did it actually in Mukhtar Sheikh, but the problem was the patient, when patient lay down in the scanner, the head is tilted, okay, to one side or the other, or the patient moved, okay, or the patient is unconscious, whatever. So I know you guys on the console can do the orientation part. I don't need to tell. I have already seen that. Okay. So you can adjust the orientation and put it as two kind of same orientation by the plane of it. Because if it's not the same, even by the 1 centimeter creates such a huge difference, you cannot comment on the mesial temporal sclerosis. You have to tell the atrophy, you have to tell the signal changes, okay, so all those things. Okay. So this is my epilepsy. These are all my cases after coming back. I have a whole inventory of those. So what happened with this patient? This patient was coming up with the uncontrolled epilepsy, not being controlled, never had a brain scan before. That's very interesting in Pakistan. Never had a brain scan. We did the brain scan. I said, I never do CT scan. I do MRI. First you spend 5,000 rupees, then you spend 7,000, 8,000 rupees again. Okay, so we did this, we find this, okay, in this patient. And that changes the management of the patient because your medicine becomes more directed for the partial secondary generalized epilepsy. Okay, your medicine regimen changes totally about that. And that helps the patient in terms of control of epilepsy. And actually, I have a video for this patient if we can play it. I don't know if it's gonna play. Okay, I'm not gonna play the whole video, but the brief video of it. So I'll just go to the next slide. So by that posture of it, we call it figure of 4. And even as a neurologist, I know what part of the brain is involved. Okay? But we already got the scan as well. And that clarifies many things in terms of the management of the patient. Coming to the movement disorder. Again, we do the general protocol as we discussed before. But please make sure to comment about the deep gray matter. Because this is a movement disorder patient. If there is a chorea, there is some Wilson's disease or something else, okay? Please make a comment. That will just tell me as a clinician that you consider my question, that this patient has a movement disorder, okay? Or there is some abnormal signal coming from somewhere. And then if you guys feel the need, you guys can do MR spectroscopy, okay? So this is one of my patients, and I know as a kind of clinician that this is my clinic. So if you look at this hand and look at this hand, even he's trying to keep both hands straight, his left hand is kind of pulled back. I didn't have the video for this one, but what do you see here? Do you think this is causing this? We call it dystonia. What do you think about this? So this patient had a road traffic accident in the past, and this was like more than 20 years ago. And his scan, if you even look at the time, was long time ago, 2006. I said, I don't need to repeat the scan, just bring your old scan. I just want to make sure what happened at that time. Okay? And he had dystonia clinically. Again, correlation helps in terms of management. According to in his own words, his symptoms are 70% better after 20 years of seeing different doctors. And to me, this is artifactual. Okay? Or there could be some other hyperintensity. You guys have a better diagnosis on the T1 scans. So we know manganese and other stuff can give you signals. Okay, demyelinating disorders. This is one of the biggest deceptor for anyone, for clinicians especially. So general protocol, then we need to do the FLAIR sagittal images. Don't miss it, please. Even I have to send one patient back to get the FLAIR sequences, sagittal sequences. And on the T1, we need to do a T1 with contrast and without contrast both. We need the coronal, sagittal, axial. Otherwise, you may not be able to pick up the disease burden. I had a patient, 30 years old girl, who was started on even immunosuppressant, not fully diagnosed as multiple sclerosis. Anyone knows McDonald's criteria? What's McDonald's criteria for multiple sclerosis? Please raise your hands. Nobody knows? There's an imaging criteria by McDonald as well. So as a radiologist, you need to know that. And if there's a question about demyelination or you think it's a demyelination, please look for it. Okay? Because that will help the clinician. There's a clinical criteria, there's an imaging criteria. Okay? So again, this sequence should not be missed in these patients. And it should be in that particular template, should be included. And it saves time. And when you report it, what happens, it happened even recently. Radiologists reported there is evidence of demyelinating disorder. Oh guys, I know this even from 100 miles, this is demyelinating disorder. This is a repeat scan. You have to tell me the number of lesions in comparison with the old scan. If you're not doing it, you're not justified. Patients are not there just to pay. Okay. The initial investigation is to diagnose. If a diagnosed case is coming, okay, and I send that patient again to Mukhtar Sheikh, why? I could have sent to some other place. Okay. Just for this reason. I didn't do the comparison. It's like, I'm very kind of, I don't know, good or bad. Guys, you need to tell me the comparison. Do it, please. Okay. What's the disease burden now? Is it better or compared to before? How many hyperintense lesions? Okay. So, and once you fulfill the criteria for MS, for that lady I was telling you guys, the cost of the medicine is 1 million rupees. How many of us can afford 1 million rupees a year for medicine and every year for the rest of the life? So you need to be very careful when you report it because it means a life change for the patient. Okay. What do you think is going on in this scan? What particular sequence is this? What do you see here? Any guesses? So this is flare, and you do see some hyperintensities, okay, periventricular. This was on the film, if you kind of guess it. It's on the film, so I don't have any other sequence. Okay, that's why my patients, even they come here or anywhere, they will always ask for the CD. And I'll say, why not make it a routine? Okay, CDs doesn't cost more than the films, for sure. Please give them a CD. Okay, because it's a record, it's a very important record. And this patient had this. What's this? You guys know better than me. What's this? Avascular necrosis of the hip, because somebody gave steroid to this patient. Okay. This was my first case in Pakistan, aquaporin 4 antibody. We proved it. Now she's on rituximab. And the rituximab cost is close to 100,000, 1 lakh rupee. Okay. How are you going to convince a patient unless you have a diagnosis? So you're going to keep doing this and causing more complications. Headache, general protocol, then you can do with contrast if there is a suspicion for RCVS or infection. And I believe RCVS is reversible cerebral vasoconstriction syndrome. Okay. Dementia, and this is second biggest population of patients, which is kind of booming, and we're going to see more and more. So beside the general sequences, please comment on the location of the atrophy. If you say small vessel ischemic changes, pathetic. I want to know where's the atrophy. Is parietal, is temporal, is frontal, where is more? We are not doing volumetric study routinely. Even in US, we don't do volumetric study. But I mean, as a clinician, I want to know what the radiologists feel. Even my suspicion is something different. And let me tell you, my dementia patients, I report myself. Because I have never seen even a single report, somebody commented what part of the brain is atrophic and it's more compared to the other parts of the brain. And then, how many of you knew about the precuneus area? Did somebody ever look at the precuneus area? This is a key sign or key component we check for Alzheimer's dementia. Most common dementia, we need to look for the precuneus atrophy. We are not looking at that. How we can comment? Alzheimer's dementia is the most common one. We can do the screening, we can do the clinical assessment, but we need to confirm. And sometimes even imaging doesn't confirm. But we need to look more. Okay? So I have seen a good number of dementia patients. So as a matter of fact, since I came back to Pakistan, all my patients I have seen so far are actually logged. I'm not presenting to CPSP or anywhere, but I kept a log because wherever I go and present, if you go to any international forum, if you're not talking about your own patient, they're not going to look upon you. They're like, this presenter is like talking about someone else's data. Okay. Try developing your data. I have been in the country for 2.5 years. I have seen close to 4,000 patients. Since I started my own clinic, I have seen 1,000 patients. I can tell you how many headaches, how many movement disorder, how many Parkinson's disease, how many epilepsy patients I have seen. Each and every patient is calculated. So what do you see here? Let's skip the sequences because it's taking a little longer. So let me know the abnormality. But it is DWI. I mean, you guys can read. Okay, so what's going on over here? You can just say there is a hyperintensities in the head of caudate and globus pallidum. What else? Is it an 80s map? It may not be very clear, but not a typical, you don't see clear hypodensity there. What this patient had? Right. So what do you think is going on? What would be the first thing in your mind if you see this image? What would be the first thing in your mind? Sorry? Okay. Bilateral basal ganglia. Okay. What else? Any big guesses? As soon as I saw this, I think about some kind of metabolic disorder. First thing first. Some kind of hypoxic insult or metabolic disorder. There's a differential. Okay, if you see the imaging evidence of deep gray involvement. And this patient clinically, and then on imaging we proved it, even we are writing a case report because this case was different, not based on the imaging, but otherwise, Wernicke's encephalopathy. We saved the life of this lady. She was in ICU for almost 5 days, undiagnosed. Cranial nerve sequences, pituitary protocol. T2 sagittal coronal fat suppressed. Again, T1 sagittal coronal hypothalamic and pituitary axis. You don't need to do everything. With contrast, looking for ectasia, okay, ectopic pituitary, sagittal coronal sequences, and then thin sections. Okay, that will also guide the surgeon where they need to approach through, like endonasal or somewhere else. Internal auditory canal. Okay, again, T1 fat suppressed axial coronal thin sections. Okay, if it's a thick section, you may miss the abnormality. It has happened with me many a times. Okay, again, T1 fat suppressed with contrast, and you have to see if there is contrast enhancement or not. Is it a lipoma? Is it a schwannoma, or what it is? Okay, and even I didn't know this thing while I was preparing this presentation because I'm not a radiologist, but I need to prepare for you guys. Okay, so report ICA loop involvement when you do that. As I said, there is no limit to perfection. If you ever think you know a lot, you're actually losing. You don't know anything. So for the orbit, T1 axial coronal fat suppressed, stir images axial coronal. Again, this is where I come across the biggest problem because people don't know how to do the orbital sequences. Okay, with contrast, axial coronal fat suppressed, and then thin sections. Okay, again, axial coronal T1 and with contrast will give you idea, and you have to very carefully look through it if you want to pick up optic neuritis. What's there? What do you see here? We used to call it like marking sign, so it's already marked. Did somebody ever look at the MRI for the optic disc swelling? You do? How many people have looked at the optic disc swelling on the orbital MRI? This patient had BIH, benign intracranial hypertension. Okay, and if you do see, the left was actually a little bit bulging compared to the right side. Okay, neuro-infections. Again, general protocol contrast study is the key. MRA, MRV can be added to the mix because you want to make sure there is no sinus thrombosis or evidence of vasculitis, which we can see in meningococcal meningitis. Delayed enhanced flare for leptomeningeal disease, especially if there is a question about sarcoidosis or leptomeningeal involvement. Neuro-oncology. General protocol, again, contrast study, MR spectroscopy, MR perfusion, and DTI images. DTI images can be done in epilepsy as well. Okay, again, when you're planning surgery. So you can do those, okay, but when you guys report, please, please, please do give a differential. Nobody writes it. It's like there is a vasogenic edema, there is a swelling, there is a cystic component. How are you going to say this is a high-grade tumor on imaging? How many of the radiology residents, they know how to grade high-grade to low-grade tumor on imaging? I know 3 things about that on the imaging. Any of you knows? Raise your hands. My radiology rotation was just 1 month in the US. So I especially appreciate at this point Taylor Davis, who was one neurology colleague, neuroradiology colleague. I used to go to him so many times. Even now I contact him. Okay, and someone who is nice, people keep coming to that person. It's a mutual learning. He is learning through me, I'm learning through him. Okay. So if you guys are going to be nice, your colleagues are going to come back to you, and it will increase your experience, your learning, because they're going to come to you with difficult cases, with complex cases, and that will increase your knowledge. Okay, so age-related differential diagnosis. I'll just come to the imaging and give you the grading of the tumor. Okay, so and the extent of involvement. What do you see here? 72-year-old lady with this mass in the brain. They call me. So what should be my opinion for this patient? What do you think? This tumor is resectable or not? Is it benign or malignant? Anyone? This is a contrast enhanced study. We all know that. There are blood vessels. Sorry? It's a malignant tumor? Okay. Any other guesses? I'll say it's benign tumor. Prove me wrong. Sorry? Diffusion restriction, yes. That will give us the idea. What else? So that is one of the three I know. What else we look for? Edema can give us the idea. What else? Where there is a tumor and the tumor is proliferating fast, he needs food. And the food comes through blood vessels. Post-contrast enhancement. Okay. What else? You need the engorgement of the blood vessel in the locality. Okay. So you do see that. Okay. And there you go. So this is the other patient actually. As a matter of fact, to this patient, she was 72 years old. She was already encephalopathic. I told them this is not resectable. Okay, keeping her age in mind and her financial status in mind. She had this on the film. I didn't ask them to repeat it. Okay, I felt this as probably a locally invasive tumor. I didn't feel it's really invasive. Okay, and by the location of it, okay, but it was lobulated and all that. Okay, but I didn't have much more to kind of comment on. But this patient, just by the look of it, as you just said, with the diffusion weighted images and all, okay, this was a high-grade tumor. Pediatric Neurology, general protocol, T1 and T2 images, below the age of 10 months, above the age of 10 months, to know the myelination, okay? And then you have to do the T2 star GRE for the calcium deposits because of torch infections, okay? MR spectroscopy you can do, especially when you're suspecting metabolic disorders, which are much more common in the kids. Assess myelination without chronological age of the patient. So first you do your reading, then you go back, and that's what I do. Even before looking at the scan, I see my patient first, guess what's going on, and then I look at the scan. Spinal imaging, axial, T2 and sagittal, T1 axial and sagittal again to compare with, stir images, T2 star axial with contrast axial sagittal and fast pressed, especially if there is a concern for demyelination. It has happened with me that the patient had a kind of an MRI again, probably a free MRI or whatnot, and there was not a locator pin. If there is no locator pin, how am I going to guess that the topmost vertebra I'm able to see is C6 or C7? Okay, you cannot guess it. You cannot tell what level is the injury. So this is for the technicians. There's a small thing you can just put there, and that will give you idea what level of the vertebra it is. They usually put it at C7, okay? And you can count it as a radiologist afterwards. So this is the most common thing what we come across, okay? Are patients with the neck ache, myelopathic features, okay? So I just want to give you guys that you have to do, look at the axial sections to kind of see how severe the stenosis. There are signal changes or not. That's what I'm interested in. And actually it has to be a good magnet MRI, otherwise spinal imaging is always a crap. Okay, what happened over here? If you kind of, anyone, quick one-liner, what's this? Sorry? Syrinx, yes, it was. And he was running around different people because somebody told him it's a demyelination. He had it for almost a year, even a repeat scan. Okay, questions. Carotid and ultrasound and stroke. How many suggest it? I see it so frequently in clinical practice, and I feel it's useless. Why? Because it doesn't give you the vessel wall. You want to know about the plaque, you cannot get the idea. You want to know about the critical stenosis, the location of the critical stenosis, you don't know. So I never do carotid ultrasound. I would rather go for MRA for renal failure patients, but I will not do a carotid ultrasound. Unless there is MRA is not available, time of flight, okay, then you can do it, okay, or maybe some other reason. I, as a neurologist, do transcranial Dopplers in the US, okay, but I don't practice that routinely. Okay. Again, unless needed, otherwise you can just guide the patient. I know sometimes clinicians, this is a wrong practice. Okay. So you can just call the clinician, you think carotid ultrasound is really necessary? I know patient will not be paying you for this extra job, but it will save time for the patient. And you can just tell the clinician that the CTA would be better. MRI negative stroke. How many of you guys must have seen a lot of MRI negative stroke so far, right? Let me know the 3 locations where you do see MRI negative stroke. I'll show you imaging as well. Somebody know cortical hand syndrome? No? It's a radiological, neurological, small thingy. So just read about cortical hand syndrome. It's a small stroke, actually embolic most of the time, in the hand knob area. Unless you do thin sections, you will never pick it up. It's a cortical area. Okay. I had 2 patients after coming back to Pakistan. In the US, I actually lost coffee from my consult because he said it's a stroke, and I said no, it's peripheral neuropathy because there was a hand drop only. And I lost coffee, but I never forget after that. Okay. So hand knob area, cortical hand syndrome. The other biggie, subthalamic. Okay. Hemiballismus. Okay. Next one, brainstem, your medulla oblongata. Okay. If you look carefully, you will still find it over there. Cerebral amyloid angiopathy. How many of you know that? What cerebral amyloid angiopathy is? Good. Anyone else? 2. What would be the best sequence to look at the cerebral amyloid angiopathy? GRE. Yes. T2 star. Patient coming in with a headache, with hemorrhages. We need to look at that. Okay. So it's very, very important. Aspect score for score. How many of you know about the aspect score for score? This is a radiological scoring, by the way. So remember, I usually tell my colleagues, don't get into someone else's circle. I'm a neurologist, I will not go to OR. Don't let the OR doctors come to your clinic. Okay? But there is always a little bit of overlap. Okay? So we used to do aspect score even as a resident in neurology, and our radiologist was doing it like on the tip of their fingers. Okay. And most of the stroke where there is not high-end imaging available in the US, it's the same thing. We think they are rich. They are rich, but not in everywhere. Okay. They do aspect scoring just on a CT scan. Okay. Even on CT scan, there is no MRI. Okay. And you say, this patient is candidate for treatment, for TPA. He's not going to bleed because it gives you the extent of damage. Germinal matrix hemorrhage. I believe you guys must have seen those before. Okay. How many of you report that? How many of you report that? I have seen reports and nobody documented germinal matrix hemorrhages. Okay. Reason for that? Because there was no GRE images. Okay. It was done. Now patient is coming to me with epilepsy or cognitive problem, and they didn't have, and nobody ever tell them that they have the germinal matrix hemorrhages as a childhood. Okay. So McDonald's criteria, we talk about that. So there is a radiological criteria. I think if I can tell you guys, please read that. Okay. Evans index, who knows about that? Another common mistake that I come across. Who knows about the Evans index? One. There's just one person. Okay. Who else? Evans index. Every report says small vessel ischemic changes, normal pressure, hydrocephalus. Wrong. Did you do Evans index? It's a radiological index. It's like when you talk with evidence. You convince the person that what I'm thinking is right. How are you going to convince it? Even if I'm neurologist and I talk to a radiologist and prove my point, I say yes, I prove myself. So prove yourself that you are consultant. You are becoming consultant. Okay? It's not that you pass FCPS. The day I felt in my training, I already knew today I'm consultant. Nobody need to tell me that day in my training. Okay? You can analyze and judge yourself. Nobody need to tell you. So this is a key slide I would like to stress upon. So as a clinician, what I need to do is a good history and examination. I should never leave that. Okay? And I need to kind of see where is the lesion. So in neurology, this is a question. Where is the lesion? What is the lesion? We always talk about that during residency and fellowship. And then comes the treatment part. Naturally, that will be decided by the clinician. But first thing I need to do is history examination, and then where is the lesion? Then, most often, it ends up in radiological assessment. Okay? And when it comes to radiology, the key person is technician and radiologist. It's not radiologist only. It's not the machine only. Okay? So the technicians need to know how to do the job, because I call my technician here my eyes and ears. If my eyes and ears are not working right, how can I prove or disapprove something? Okay, so trust your technician first, and they should be trained. Okay, and then radiologists need to refresh themselves. Keep reading, that never ends. And then you can tell me what is the lesion. You cannot tell what kind of lesion is it, okay? But naturally, the treatment patient need to come back to me. When it comes to radiology, again, the technician is very important because they know what they're doing in the lab. Pathologist sitting in the office doesn't know. So they should be trained, and the pathologist should be refreshing themselves so they can again answer the question, what is the lesion or what is the problem, okay? And then in the neurophysiology lab, which is mainly taken care by the neurophysicians, again, technician and neurophysiologist, and it helps us again with the question, where is the lesion? Because this is more sensitive testing. Reporting gaps, size and location of the hemorrhage, hypoxic injury and deep gray matter involvement, comparison with the last scan, reporting edema on the CT scan. This is the worst. Unless it's so obvious, like mild edema on the CT scan. Who's going to prove it? Who's going to disapprove it? I just put that scan to the side. Please get an MRI. Prove it. Okay. Yeah. So mild edema on the CT scan. I really find it funny. Okay. Reporting time. It happened with me. I think this is again a big limiting issue in the private practice. Okay. You send a patient for the scan, and you are expecting a scan same day, and then getting the report, if not the same day but next day, but it takes 3 days. Patient is already gone. Okay. So hard. In our system, there are so many limitations. I know everybody is busy, but serious patients takes the precedence. So you need to know who is serious, who is not. So for sake of time, so this was the stroke. Only on one section, on DWI. Okay, we proved it clinically. I have the video, I'm not going to show you guys, but this was and then this was the case, and here it is. And then we did the repeat scan on this patient. So these are some of the radiology resources. This is the Duke Hospital's website. It's one of the best resource. It has some issues opening up in every system in Pakistan, but you can check it. If you can do it, believe me, you will never regret it. This is the best in terms of how many ways you're going to look at the brain, even in the small areas. Okay, it gives you the even imaging coding and everything, name of it. Okay, even the CT as well. So this is very good. Radiopedia, I believe everybody is reading it. Okay, there's a lot of information on Radiopedia. Do that. My go-to favorite is Osborne. Okay. And I was a neurology resident. I have the textbook. I even have the online version. So I keep reading, keep going back to that again and again because it's a mutual learning, and I keep going back to my radiology colleague. And then Neuroradiology, the requisites is a smaller book, but it has a lot of compact information. Okay. Then Neuroradiology in clinical practice. Okay. Again, at some point in my life, I did kind of read through many of those, but this is kind of my go-to right now. And if I need to look at internet, I kind of look these two. I'm open for any questions. Thank you very much for your patient listening. I know it may not be a lot.